Yang Berhormat Datuk Seri Dr. Dzulkefly Ahmad, former Minister of Health Malaysia and Chairman of Selangor New Special Action Council for the Control and Prevention of COVID-19, Tan Sri Majikan, Deputy Chairman of KSI, Excellencies, distinguished guests, ladies and gentlemen. Hello everyone. Firstly, on behalf of the President of KSI, Strategic Institute for Asia Pacific, Tan Sri Michael Yeo, he sends his apologies as he is not able to be here in person to greet YB Datuk Seri as he has to attend to an urgent meeting. When we first mooted the idea of this event way back in February 2020, we were still living in the old normal. However, life as we know has come to pass and we are now living the new normal. The pandemic has truly disrupted our lives. It has created economic chaos and so much disruption and uncertainty. We are all still learning to adjust to the new normal, some better than the others, but life goes on. Ladies and gentlemen, without further ado, it's my pleasure to welcome Yang Berhormat Datuk Seri Dr. Haji Dzulkefly Ahmad to deliver his special address. Many of you have already known him by his name and his contribution to the Malaysian healthcare public sector. Yang Berhormat Datuk Seri is also the head of the Selangor COVID-19 Task Force Council to tackle the pandemic in the state. So let's give him a round of warm applause for YB Datuk Seri.
Thank you, Ms. Cheong. Distinguished guests, ladies and gentlemen, please put your hands together as we welcome Yang Berhormat Datuk Seri Dzulkefly Ahmad, Chairman of Selangor's new Special Action Council for the Control and Prevention of the Coronavirus Disease.
Thank you. Thank you, Mr. Chair. Ms. Caroline Cheong, Chief Operating Officer and Executive Director of the Research and Program KSI, Strategic Institute for Asia Pacific. Tan Sri Majid Khan, the Deputy Chairman of KSI. Excellencies, distinguished speakers and guests, Tan Sris, ladies and gentlemen, may I begin my presentation by my usual salam of Assalamu alaikum rahmatullahi wa barakatuh, and a very good afternoon. I first and foremost would like to thank for this invite to Tan Sri Michael Yeo, and it's such a great pleasure and honor to be able to address you, distinguished audience in this Malaysian Healthcare Conference, especially after being ousted and no longer or sitting on the other side of the bench. And so really, truly a kind gesture on the part of Tan Sri Michael Yeo to invite me along, well, with all other distinguished speakers for this healthcare conference. May I begin by saying that the COVID-19 pandemic is, in a sense, the ultimate test in administrative law and governance. Besides, it may also be perceived as a proxy indicator of the preparedness of the public health system of a country. Faced with a global pandemic threat, every government on the planet faces essentially the same health challenges. Some were, of course, on their knees more than others. Inter alia, to one, protect its people from a contagious disease by regulating public and private conduct as to minimize the disease transmission at a manageable cost to the economy. Hence, countries' performance in meeting these tasks could then be measured in very objective terms, namely A, morbidities, B, mortalities, C, loss of job and GDP impairment, and of course the loss of social cohesions, i.e. impact on livelihood beyond economics, the psychosocial impacts including domestic violence, divorce, depression, and what have you. To cite South Korea as one of the more successful countries in flattening the epidemic curve quickly, without closing businesses or issuing stay orders or restricting movement adopted by other higher income economies. These early successes across the three preparedness response framework essentially premise on detection, containment, and treatment. One defining feature of the critical success factors, namely an intense collaboration between government and the scientific community. That is the particular features of the experience and success of South Korea. Apart from, of course, subsequently you see some other outbreaks and what have you. The debate on the COVID-19 in the Malaysian Parliament yesterday witnessed the finance minister arguably admitting that Malaysia suffered the worst GDP growth in our second quarter this year, 2020, the worst in ASEAN, and in fact globally too. Essentially because our MCO measures were among the more stringent and more extended. That's the price you pay, the damage you pay for ascertaining balancing between life and livelihood. It goes without saying too that the current COVID-19 pandemic puts a previously unseen stress on the organization of healthcare. In several countries, although arguably may have not reached that critical stage, the demand for medical care exceeds the available resources, hence urging stakeholders and technocrats to reorganize medical landscape. Be that as it may, let me get to discussing the subject matter that I'm requested to dwell on, i.e. the importance of primary care or primary health care, I take it interchangeably, and the impact of COVID-19. WHO defined primary health care as a whole of society approach to health and well-being, premised and centered on the needs and preferences of individuals, families, and communities. WHO explains primary health care ranging from the continuum of care, ranging from promotion and prevention to treatment, rehabilitation, and palliative care. As close as and as feasible to people's everyday environment, essentially looking after the non-communicable diseases more than the communicable diseases of the infectious diseases of dengue and now, of course, the pandemic of virus SARS-CoV-2, pandemic COVID-19. It goes without saying as well that access to healthcare is a fundamental right. But the strain that the COVID-19 pandemic has placed on healthcare systems everywhere has, in turn, affected many people's primary care provision. Adversely, of course. Due to fears relating to the spread of the SARS-CoV-2 virus, healthcare providers, including the primary healthcare providers, particularly around the world, have been minimizing in-person contacts with their patients. This has affected prenatal care, as an example, a crucial aspect of ensuring that pregnant women and developing babies stay healthy throughout their pregnancy. The pandemic has surely jeopardized this regular prenatal visit to family medicine clinicians in healthcare clinics, both public and as well, Dr. Gill did, in the private settings. Primary healthcare, goes without saying again, and I don't need to overemphasize this, is an essential foundation for the global response to coronavirus 2019, COVID-19. Primary care plays a significant role in gatekeeping in the gatekeeping role and in clinical responses, early clinical responses, differentiating and triaging patients with respiratory symptoms from those with COVID-19, making an early diagnosis, helping vulnerable people with their anxiety about the virus, and reducing the demand for hospital-based services or acute care services. May I just allude you to the actions in the primary care. The main principle of primary care in the light of COVID-19 is to identify and manage potential cases, avert risk of transmission of infection to particularly contact and health workers, 3, to maintain delivery of essential health services and enhance existing surveillance, sentinel surveillance kind of things, such as the influenza-like illnesses, the ILI, and the severe acute respiratory infection. And finally, to strengthen risk communication and communication, and particularly community engagement. But if I may, just allude you to the requirement of, if I just summarize quickly, of the infrastructural needs of, for example, I will illustrate further with Malaysian experience of the need to identify a dedicated isolation room that must be available during the opening hours of the health facilities, setting up adequate signage and information notices, ensuring isolation room has a dedicated waiting, and all those requirements, the infrastructure requirement. And for healthcare workers, to allocate an adequate numbers of healthcare workers to attend to patients with suspected or confirmed COVID cases while maintaining essential services. Be that as it may, if I may, despite all this SOPs, guidelines for general practice and family medicine practice, I would just quote of an original research paper here. Impact of COVID-19 pandemic on the core function of primary care. Will the cure be worse than the disease? It's not the medicine killing the patient, but will the cure be worse than the disease? If I could just summarize these studies, the objective was to measure, how does COVID-19 impact on healthcare? And the study was to set up and to gain insight into the consequences of the COVID-19 outbreak on the core competencies of general practice as they are experienced by general practitioners as the front liner. And if I may just read you the conclusion. The current times have a profound impact on the core competencies of primary care. Although the vast increase in patients soliciting medical help and the necessary separate COVID and non-COVID flows have been dealt with, GPs are worried about the continuity of regular care and consequences of the anti-COVID measures. These may become a threat for the general health of population, particularly of the non-COVID cases, and for the provisions of primary health care in the near and distant future. That was the concern, the anxiety, as noted in the conclusion. If I may just quickly move to what is the situation and the experience in Malaysia. I was fortunate as I was preparing for this speech to have bumped into this write-up by Dr. Nazrila and Dr. Koshi published this work on primary healthcare initiatives in Malaysia, where I could just read some of the excerpts on their paper that says, in Malaysia, the Ministry of Health initiated its preparedness plan on January 9. That was when I was still around. I left 24th February, by the way. I tweeted as my last tweet for SNS as the YBMK. A full 2 weeks before the first case was reported in the country, we had that capacity building of sort and training of sort. And well ahead of WHO declaring COVID-19 as a pandemic, which I think it was on 11th of March, if I'm not mistaken, if my memory doesn't fail me. The Ministry of Health of Malaysia led a rapid, coordinated effort to adapt to the entire health sector in response to the COVID-19 pandemic and the MCOs, the Movement Control Order, particularly at the primary care level. These adaptations were intended to ensure adequate resourcing for the pandemic response effort while continuing essential health services and protecting the safety and well-being of both patients and providers, the frontliners. Much of this was made possible by the country's early investment in and commitment to building a strong and coordinated primary healthcare system. In a way, as a response to the last epidemic of SARS of 2003, if I'm not mistaken, yeah. So new triage and screening practices were implemented to reduce possible transmission of COVID-19 between patients. Waiting areas were organized, as was alluded earlier, of the needs of the various SOPs, such that patients with respiratory symptoms were kept separate from other patients, and all waiting areas were equipped with sanitary equipments and arranged according to social distancing best practice. Facilities with low patient volume redeployed their staff to higher volume facilities to help manage the influx of patients. A key element of the MOH effort to promote the continued utilization of services while maintaining social distancing was a series of new and adapted initiatives that allowed people to seek information, medicine, and routine care through low or no contact means at all. The MOH quickly established a virtual health advisory through which patients with symptoms or even just concern could access a rapid, credible information. Through a collaboration with a private sector online medical consultation company, the MOH established a custom web portal that allowed patients to engage in free audio, video, and text chats with family medicine specialists. These are among the good initiatives that MOH were able to do. In another private sector partnership, the MOH implemented a new online appointment system for public health clinic visits. Dr. Kuljit will testify to that, or do you disagree? Significantly reducing in-clinic waiting time and allowing people to schedule and reschedule visits according to their availability and convenience. The MOH also initiated virtual public health clinics, which they plan to expand to an additional 35 sites during the pandemic. These clinics reduce the need to travel to health facilities while also making care more accessible and cheaper to provide. And I must say that without going through the entire thing that I've thought would be pertinent to be mentioned, you could say that MOH has responded well and put in place critical, pertinent initiatives, to address the need. And there are other things that I would make a mention of, how patients can now access prescription via mail, contactless pickup lockers and drive-through pharmacies and whatnot. Yeah. However, unfortunately, there have been a number of health services offered at the country's public health facilities that have been reprioritized and thus deferred during the pandemic. So these are, what has become compromised or takes its toll. The majority of these services are group-based, including health camp, cooking demonstration, and health education activities, which would have caused difficulty in practicing social distancing, of course. Counseling, rehabilitation, and in-person health screening have all been deferred as well. While these are all considered an important health services, this unprecedented, crisis situation necessitates difficult decision, to be put in order. We need a different crisis management in crisis time. Despite this effort, Malaysia was hard hit over the first few months of the COVID-19 pandemic. That was during the acceleration phase, after I left, of course. It was that CEO of Khazanah, CEO of UDA, if you correctly recall yourself, and of course the Sri Petaling clusters. A large, dense and mobile population made containment immensely difficult. As you know very well, this disease is a function of density, of congestion and whatever. Hence the reason why you see Selangor having those cases. But however, using 100,000 population per capita, it is not as high as Wilayah Kuala Lumpur, and others. The relative success of Malaysian MOH at limiting COVID-19 cases and death and achieving steady improvement was due to ministry's, I must say, good work, swift mobilization of health sector, which would not have been possible without strong foundation of a public health care system that Malaysia has built over the years. And with that, I must say that we are fortunate that hospitals have not been overwhelmed. I thought never were we overwhelmed, But and that's the reason why we were able to flatten the curve as we delay, using all these mitigating measures. And finally, of course, through the MCOs and the various types of the MCOs. But there's scope for us to ensure that we do not compromise on the non-COVID cases. This is what I thought is implied in this topic. Probably not relevant right now, as cases are so low, but even when it is higher, some of the milder cases, low-risk cases, can be managed in primary care setting. And there should be efforts in that direction. And we should see to more enhancement of our primary care system to strengthen and consolidate and fortify their management and as well funding for it to be as equal to the secondary and the tertiary, the hospital-based setting. And there's all the need for us to address the non-communicable diseases as it is the dominant factor in causing premature death and plateauing of our longevity of our lifespan of Malaysians. So surely, it's time for us to take stock while we can pat our back over our success in managing COVID-19. We must also at the same time be reminded, that the non-COVID cases of non-communicable diseases, highest being cause of death is IHD, ischemic heart diseases at 16.1%. As well, the cardiovascular accidents, of strokes, of other sequelae of hypertension, diabetes, which are also very costly in reducing the productivity of this nation. That surely require, looking into reforms and strategizing, because infectious disease by nature is episodal and acute, while non-communicable disease is a life span. And all the more, you've got to be putting in perspective. While COVID-19 is very emotive, yes, but the emphasis, for us to be equitably distributing our funds and our investment in primary care as the gatekeeping role for NCDs cannot be overemphasized. So with that, I would say COVID-19, even though is a communicable disease, it reveals a non-communicable disease crisis of obesity, diabetes, and what have you, that have made COVID-19 more deadly. I could not overemphasize this point in my conclusion. So all the more reason why appropriate enhancement of funding and reforms are critically in need to enhance further our healthcare delivery and system in our country. So the outcome of COVID-19, finally, if I may say, the outcome of COVID-19 cannot be a weakened health system with less public financing. If anything, it should strengthen further a coordinated, comprehensive, greater continuity of care, or the continuum of care that must be put in place. With that, I thank you for your kind attention.